This discussion really interesting. We wish we could have similar discussion over the year whenever important trials come out, etc. So we've created this blog, and sometimes people like to write a blog, and others would prefer to have a chat. And actually, chat are very nice. So thank you so much for accepting to chat about this adaptable trial. And actually, this is a very landmark trial, not necessarily because of the results, and you will maybe introduce us to the main findings of the trial, but mainly because of the model of running a trial. They call it a pragmatic trial. And you have editorialized the main paper in New England Journal of Medicine. And so we thought that you are best positioned in order really to comment about the pluses and minuses of these type of adaptive trials. So just in a few words, what are the main findings? And then we'll get to the concept of pragmatic trials.
Sure. Well, this was a trial of around 15,000 patients with established cardiovascular disease, randomized between 81 milligrams and 325 milligrams of aspirin. And the notion was that there was uncertainty about whether there were differences in the efficacy or safety of those two doses of aspirin. And so they postulated that there might be up to, say, a 15% difference. So 325 might be 15% more effective in terms of reducing the primary endpoint, death, hospitalization due to MI or stroke. So that was the design of the study. That they ran the study for just over 2 years, medium follow-up, and the results showed no significant difference between the two arms. We can go into some of the important caveats around the results in a moment, but perhaps we should talk a bit about the design and how they pulled off this 15,000 patient study using this novel method. Well, novel for the US, not really novel internationally, but novel for the US.
Sure, yes, because this trial was funded and conducted by the NIH, right?
Yes, they use the patient-centered outcome research network, PCORNet. There's about 40 centers in the US collaborated, and they used methods which have been used in various places around the world, including in our own center, whereby they try to identify people for the trial who might be potentially eligible by interrogating electronic databases. They called it a computable phenotype. So they basically tried to find people who are already in their system and then invite them. And this, of course, is a very efficient way of identifying people. The old method, whereby you just wait for people to come into your clinic, means that you just really have to wait for them to turn up. Whereas if you can identify a large group of them, then you can immediately potentially randomize very large numbers. And that's why they only had 40 centers to randomize 50,000 patients, 15,000 patients, I should say. And this approach has been advocated for some time now. And the whole idea of quality by design, whereby one puts emphasis on trying to get the most reliable results by paying attention to things that really matter for trial design and what really matter for the safety and the well-being of the patient. So that extends to things like just thinking about what sort of monitoring and training is needed. The sort of approach of CROs of 100% source verification, very frequently is just not appropriate in many cases, particularly questions like this where aspirin is a very well-studied drug and the main effects of it are known. So the approach they took really just says, can we really do this in the US? And they showed absolutely it can be done in the US, just as it can be done in other countries where good electronic records are kept of patient care.
So this is called pragmatic. What does that mean? That means simple? Just the pragmatic points out to the simplicity of the trial, or there are other features of having a pragmatic approach?
Well, I think that the definition of a pragmatic trial actually varies depending on who you talk to. Some people think that what this really ought to mean is that you try and replicate real life practice as much as possible. And I think, and this is one definition, and in fact, you can read about it in various reviews. But I think this is actually the wrong notion of how we should be doing trials, and I think it's widely held view in other people feel that what really matters is that you pay attention to the things that are important in getting a very clear result, and in making sure that patients are kept safe during the trial. So to give an example, it is often said that you have to basically replicate clinical practice. So all the sort of noisiness that goes on around patient care has to be replicated. And if you don't do that, it's not a reliable result. I don't think that's the right approach. What you're really interested in finding out is, does the treatment, if it's taken, work? And in what sense does it work? And any noise you add, any things that get in the way of getting that result are actually not a good thing for the trial. So the design really has to be to try to pay attention to the fundamentals. First of all, you have to get the randomization right. There has to be good comparability between the groups, so that there are no selection biases that might influence the results. Then you have to make sure that patients actually take their treatments, because if they don't take the treatments, you're not testing the drug. Then you have to make sure that you record all the outcomes that you're interested in and are relevant to making a judgment about the drug. And then you have to analyze it correctly.
Sorry to interrupt. All these features are the features of a successful trial. It indicates how is it different in the pragmatic world? Why we need to be more careful with this in a pragmatic design?
Because in many cases, the design is, for pragmatic trials, I think what the word you used earlier is simple, or streamlined is a more sensible description, whereby attention is paid to every single element of the trial to try to reduce the complexity, to reduce the cost, to avoid doing things which obscure the results. And that's why I was talking about embedding. The idea is that pragmatic trials should be embedded in what's going on normally. Well, that's all very well, provided that you don't add in elements that actually create noise and prevent you from being able to detect the effect of the drug. So the beauty of what they did in PCORNet in this trial was that they identified people from databases they already had. They were able to work out, they were able to get a sample size of 15,000 from 40 centers. They collected data routinely through a patient portal and through electronic health records. They didn't adjudicate because they didn't think it was necessary to be sure that somebody had had an event. And all these elements go together to create a streamlined approach to a randomized trial. And in particular, in this case, where the trial was an open trial, it's even more important to make sure that the design is streamlined in a way that does not create bias. So you can imagine that you could streamline it in a way that potentially created bias, but they try very hard to avoid that.